We are delighted to have Professor Roxana Mehran speaking to us. So Professor Mehran was not able to be here with us in person, but she will be joining us virtually shortly. She's the endowed Mount Sinai Professor in Cardiovascular Clinical Research Outcomes. She's the Professor of Medicine and Population Health Science and Policy at the Icahn School of Medicine at Mount Sinai. And she's a renowned interventional cardiologist who has been involved in a number of groundbreaking clinical trials. And crucially, for the purpose of today's lecture, she's also the chair of the Lancet Global Commission for Women and Cardiovascular Disease. So no better person to speak to us about the burden of cardiovascular disease in women, and her lecture is entitled Reducing the Global Burden of Cardiovascular Disease in Women, a 2020 Vision for 2030. So Professor Mehran, welcome.
And let me begin by thanking all of you and the incredible honor of working on the Lancet Women and Cardiovascular Disease Commission and bringing forward to you some of our findings and the vision for 2030. These are my disclosures, important for all of you to note, but nothing in relation to this particular commission, which was coming through the Lancet for working with a lot of leaders around the country and the world on addressing some of the gaps in sex-based research, understanding the global burden of disease across the globe and for women, cardiovascular disease in women, and to come up with solutions, because I think most of you must know what's going on in the world, but I'll share some of it with you. I was very lucky to work with some of these senior commissioners from the US, South America, and of course, Europe, and the entire group, all women, I'm proud to say, all incredible experts in the arena and representing every part of the world here. Aims of the commission, first and foremost, is to reduce the global burden of cardiovascular disease by 2030. We need to do this by promoting cardiovascular health and improving outcomes of women worldwide. And we can't do it without identifying existing evidence and the gaps in cardiovascular research, treatment, access to care, and prevention in women. And we hope, and we believe we already have, igniting a global awareness of sex and gender-specific disparities in cardiovascular disease, and hopefully, if not already, providing a springboard for future research. Disease and the prevalence declined between 1990 to 2010, and that was wonderful to see, especially when awareness was put forth on a very, very huge effort by many. But since 2010, in the last decade or so, there's actually been an increase. That rate of decline has slowed down. And in fact, there is an increase in certain high-income countries like US and Canada. Cardiovascular disease is the leading cause of mortality in women. These are data published in Circulation by Amelia Benjamin. 1.2 million women died in the United States in 2016. Of those deaths, cardiovascular disease was the cause of 412,000 of those deaths. If you line up the next 7 causes of death in women, it would pale in comparison to this number of 412,000 women dying of heart disease. In fact, we have seen and observed and looked at the data in 2019, looking at the global burden of disease study in 2019, which was published in the Lancet, and the tools are available online. And now through this commission, we have made it available on our website, which I will share with you so that you don't have to do too much work to to understand that cardiovascular disease is responsible for about 35% of all deaths in women, whereas cancer is about 17%. That is not to ignore cancer, but we absolutely need to focus on cardiovascular disease. And the decline that has slowed and the mortality that is increasing in these countries, you see them, the slope of the curve is going in the wrong direction. And we need to understand, why is it that there are increase in recent years in myocardial infarction in younger women? Is it because we're now diagnosing it? We're paying more attention to it? Was it always there that we just never saw? One never knows, but we do know that in the United States, for women less than the age of 55, we are seeing an increase, a rise in hospital admissions for acute coronary syndromes. And in fact, trends are being seen in France and in other countries. You see that on the left panel here for STEMI, non-STEMI, ST segment elevation and non-ST segment elevation MI increasing by an order of about 6% in France for women less than the age of 65. And we're learning very clearly that there are very important social determinants of health that have been previously ignored. And now we pay a lot of attention to this. And this is work by Greg Roth, published in JACC, where in socially deprived regions, women have higher cardiovascular disease mortality than men, especially those with minority ethnicity, where they are overrepresented in areas living in poverty, even in high-income countries. This isn't about low-income developing countries, which we see this prevalence, but the difficult part is to see this right here in our backyards. Women are especially affected by the association of low socioeconomic status and cardiovascular risk. Awareness that heart disease is the leading cause of death right here in the United States over the last decade has decreased, particularly those exact population, Hispanic, non-Hispanic Black women, younger women, where primary prevention would be absolutely effective. We see this, that 40% of women incorrectly believe that cancer is the #1 cause of death. So an urgent redoubling of efforts by organizations such as SHARP and others interested in women's health is required to reverse this awful, awful pattern and trends we're observing. The knowledge, attitude, and beliefs regarding cardiovascular disease, this is a survey in the United States, only 40% of routine care includes actually a heart risk evaluation. All primary care physicians, only 40% make that a priority. And only 20% of primary care physicians and 42% of cardiologists feel that they're prepared actually to evaluate risk of cardiovascular disease assessment. That just seems absolutely unconscionable. Cardiovascular risk factors that are not only increasing, but that we are ignoring. We need to understand better how to include these in our risk assessments. When was the last time you evaluated for gestational diabetes, hypertension, preeclampsia, preterm birth, or any pregnancy-related complication in a 60-year-old woman that you see in your office? We believe also the younger women, those with early menarche, polycystic ovarian disease, those who are on birth control, as well as preterm menopause, need to be evaluated. And of course, the whole idea of understanding hormone replacement therapy in elderly still remains somewhat unclear on so many levels. But also there are important risk factors that are still under-recognized, in addition to the sex-specific risk factors, and they're actually strongly associated with female gender, and importantly, associated with a woman's social and physical environment. And those include social risk factors, abuse, intimate partner, violence, socioeconomic deprivation, and poor health literacy, and environmental risk factors with the changing climate. There is no stronger reminder than the COVID-19 pandemic on how sex and gender-related factors interact to negatively affect a woman's cardiovascular health. The pandemic showed exorbitantly how socioeconomic status and the cultural role of women in society affect the physical and mental health and the well-being of women globally. Mental health matters, and we really have not paid attention to this. The InterHeart study did show that psychosocial illness has a very, very important impact on cardiovascular risk, just as important as an elevated LDL, hypertension, or diabetes. Yet we don't really seek to understand what's happening in the personal lives of women when they come to our office. Found that the pathobiology and the physiology of heart disease in women is very different. We are not just small men. And that there is very important other issues outside of non-atherosclerotic, and perhaps understanding better about what is happening in a woman's cardiovascular disease in terms of course, atherosclerosis, but also spontaneous coronary artery dissection, myocardial infarction with non-obstructive coronary disease, ischemia with non-obstructive coronary disease, and Takotsubo syndrome. Knowledge gap in prevalence, diagnosis, treatment, and outcomes exists here. When women do present with a myocardial infarction, they are less likely to be treated according to guideline-directed therapies, much less likely to receive antiplatelet therapies, lipid-lowering therapies, coronary revascularization, beta blockers. It just makes no sense. And in fact, if you look on the right side of this panel, the trends in percentage of men and women filling a high-intensity statin prescription after a hospital discharge for myocardial infarction is that so much lower for women. Women are almost never sent home with high-intensity statin therapy. So the bottom line is that women are underrepresented a lot in cardiovascular clinical trials. And of course, we have seen legislation passed on this, and we keep talking about this, but the action hasn't been there. We know that the sex-specific data are underreported, and all of this limits our potential for developing sex-specific strategies, recommendations, and even guidelines. The guidelines are really written for the white male population. We really have to rethink this. It's very, very important is that the underrepresentation of women in our clinical trials, and you look at this, of course, pulmonary hypertension doing well because it's a prevalent disease in women, but in heart failure, acute coronary syndromes, coronary disease, stroke, and arrhythmia trials, all below where it needs to be. It is not representing the population at large. So I want to tell you that cardiovascular disease in women remains understudied, underrecognized, underdiagnosed, and undertreated. And we need to think about this most vulnerable populations as our lowest hanging fruit to deal with. Women living in socially deprived regions have higher mortality, huge gap in education level, little access to healthcare. And of course, it's all about this poverty, malnutrition, migration, uncontrolled fertility, and complications of childhood contributing to cardiovascular disease. So the strategies, as we laid out in the Lancet Commission, was comprehensive action. education, and community health workers to support this, because we just don't have enough healthcare professionals to actually do this. Especially, there are hardly any women in cardiologists. And that's a whole nother story that you have to invite me back for to talk to you about. Women living, their role is very much defined by traditional and religious norms, is another area of focus. And our strategies in the commission was to be culturally sensitive to the primary and secondary prevention programs. You cannot just come in with a bulldozer and say, here's what you've got to do. You have to be sensitive. You have to empower women through education, establishing equal opportunities for higher education, political life and economic activity, and enabling them to view themselves as the decision makers, because they really are decision makers in the healthcare of the entire family. And we need now to empower them. And of course, in Indigenous populations and low socioeconomic status, where there's almost no insurance or healthcare coverage and inadequate infrastructure, we need to have language-specific, culturally specific, peer-to-peer mentoring, being cognizant of their historical and important inequalities that has been upon them for years and years. And then imagine those culturally tailored communications and assessing healthcare literacy. And think about telehealth. Here's one thing we got out of COVID-19, telehealth. Let's see that by really enabling, hopefully, evaluation. Young women absolutely need to be engaged earlier. We have to develop important risk assessment, understanding this pathobiology of acute MI in the young women and the associated higher mortality. The huge issue is smoking cessation. And we have no idea what e-cigarettes and vaping are doing to our women. And especially in different parts of the world, it could also be hookah smoking, which we've seen. So the recommendation were to close the gaps, enhance awareness, target well-established sex-specific under-recognized risk factors, and strengthen healthcare system to engage healthcare professionals. Closing gaps requires us to adhere to policies and guidelines in considering sex and gender variables in our research design. We have to power our trials. Specific analyses, we never do that. I'm a trialist and I often ask for this, and I'm often told, well, we have to get enrollment done. We have to initiate research studies to explore potential biological pathways that might underpin sex and gender as determinants of cardiovascular health. And we have to establish robust national and regional health surveillance systems. There's a lot of work to do, and I hope that some of this is really you're relating to some of this as an important area. One of the things we laid out in the commission was the strategies. We really want to come up with some solutions. Enough of complaining about what's going on. Let's do something. So let's make sure we take that upper and lower age limits exclusions out of our criteria. Think about the fact they're always excluding women of childbearing age from pretty much every clinical trial in cardiovascular disease. Now, aren't they women also? Don't they have risk factors? Should we not understand what to do for women of childbearing age? We need to exchange knowledge, educate, and recruit personnel on importance of enrolling women in clinical trials, sharing experiences amongst our peers, and then your clinical trial, you need to go to where they are. Those outreach community programs in settings that are frequented for women, where women are going to, involving our primary care physicians, educating them, bringing those to us, and providing very important information on the risks, but also the benefits of participating in clinical trials. And most importantly, you cannot expect women to yet have one more thing on their plate. Their cup runneth over. They're taking care of the entire family. A lot of them are single women with multiple jobs. So we need to remove the barriers of arranging childcare, free transportation, and offering flex hours and even at-home follow-up or telehealth. Why haven't we thought about this? It really is simple. We just don't think about what women are going through. Enhancing awareness of cardiovascular disease in women is extremely important. The fact that over the last decade, awareness has decreased is something we need to kind of change. And this absolutely requires government-initiated and supported public education activities, assessing health literacy and cultural sensitivities, very important, and using some of the traditional but also digital communications, especially if we're targeting younger women, and empowering them in all parts of the world through education. And of course, understanding these well-established, we shouldn't forget about the well-established risk factors like hyperlipidemia, hypertension. Those are really, really important and contribute to ischemic heart disease, absolutely, and are responsible for a lot of this. But we also need to think about the sex-specific and under-recognized risk factors and really, really enhancing and implementing women-specific clinical guidelines for cardiovascular prevention. How do we do that? I propose, instead of pushing the bar of, oh, let's enroll more women, how do we get more women? And we see these trials, especially lipid-lowering trials, 75%, almost 80% being men. Why not just do trials in women? Just doing that. I think scaling up these heart programs and involving multiple stakeholders will be incredibly important. We also have to strengthen the healthcare systems and engaging healthcare professionals. And of course, primary care physicians, relevant subspecialties. I'm working with our obstetricians, gynecologists, emergency medicine, rheumatology, and of course, a very important arena of cardio-oncology, working with our oncologists, but also go to these non-conventional care settings to initiate discussions. And I truly believe, and this is a schematic from the paper, that with socioeconomic factors in the background, we have every opportunity from inception to end of life of a woman to intervene. It is never too early. It is never too late. And I think what you are seeing, we published the paper in 2021 in the Lancet, and the first year of 2022 was completely devoted to a very important year of awareness. We absolutely put our horns on, and this is one of them, and this is one of the congresses, and I'm really, really grateful to be able to absolutely speak to all of you. We worked hard in the American College of Cardiology with top speakers being part of that, as well as the European Society of Cardiology with multitudes of fantastic faculty, program agenda that included all of the things that we're talking about, with cases, with keynote lectures, with understanding, for example, myocardial infarction in women, the young, the poor, the non-white. That was an incredible keynote lecture by Dr. Sadia Khan from Northwestern. We worked very hard to think about case-based, and I urge you to do these types of educational forums. And I'm happy to send you this kind of agenda and share with you all of my slides so you could share within your communities what absolutely needs to be done. We went to the ESC focusing on heart failure in women. And that was a huge forum where we were able to engage top-notch leaders around the world to talk about heart failure in women. And of course, they have very, very full understanding that we are absolutely working very, very hard on in February 2023, inviting you all to come and work with us and come and spread the news about women and cardiovascular disease and help us all rise to a much better place. We have to also be very, very open. What we did with the commission, we set up a website. In this website, womencbdcommission.org, and I hope that you all go to it. We have stories, patient stories there. We have women with microvascular disease living with vasospastic disease and microvascular disease, telling their stories and how much they've been ignored from emergency room to emergency room until someone finally paid attention and made the diagnosis. We have featured videos of important web conferences that we've put together. And of course, working together with the International Heart Spasms Alliance to really bring forth some of these important patient advocates and making them more visible. We've also worked hard to map the entire global burden of disease in women into this website. Because if you go to the GBD website, you would have to work about 2 months to find out where is rheumatic heart disease, for example, very, very important in what part of the world in women. And you'll be able to find that going to this website because we brought the tools and we made that happen. We've done user-friendly data visualization tool on the commission website. And please feel free to go there. It won't charge you. It will not charge you anything. There's no charge. It's completely free. We want you to take this and show it to your constituencies to understand that we absolutely must do something. These are going to be yearly updated of these data, and we're working very, very hard on this with the global burden of disease so that we could have real-time, close attention to what's going on around the world. So please visit our website at womencbdcommission.org. And I want to thank you for your attention and having me at this Congress. Thank you so much.
Thank you, that was great. You would be forgiven for thinking that cardiovascular disease was mainly a problem of men. I think in Scotland it's perhaps, as you said, partly people's awareness is poor. Given that the risk factors are different, are you aware of the development of any risk assessment questionnaires that take into account some of the female-only factors?
So since the data is really not very, very clear, the American Heart Association, the ACC, and even ESC have not come up with those risk calculators. So it's really difficult to say, validated risk calculators are available for female-specific risk factors. And we believe that these sex-specific risk factors have to be collected, evaluated. There's no question now that pregnancy-related complications, there's enough ample evidence that there is a tremendous relationship, whether it's causal or not, one never knows. Understanding the pathobiology of why if a woman has a preterm low birth weight baby, she's at a higher risk for cardiovascular disease down the line and risk factors, for example, developing hypertension, even though she didn't have gestational or preeclampsia or any of that, just a low birth weight baby is unclear. So to say that these risk factors have been validated and available to everyone, it really would not be true, but that I believe we absolutely need to collect this and continue to study the important relationship that we're observing at the moment, and then to validate it across the globe. But thank you for that question. And I hope that you're all thinking about those in your evaluation of women when they're coming to your clinics.
Thank you, Mary Jo.
Thank you, that was very interesting. You mentioned that women are less likely to be included in clinical trials, and I just wanted to explore that a little more. In stroke, I work in stroke, obviously women are older, and therefore they either don't fit the inclusion criteria, or family say we'd rather they weren't included because they may not have capacity. But I wondered overall, is the issue that the inclusion criteria of studies are set up to favour men because of the risk profile, or is the issue the patients or women not wanting to be involved in clinical trials? And if so, is there any PPI work to try and identify which factors would improve inclusion of women in trials?
So thank you for that question. It's a really important and crucial question. The answer is yes, 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 all of the above. And I think there's no question that, number one, we are, the way we set our clinical trials, a lot of them led by industry, and I work with industry colleagues very, very closely. But as you can imagine, especially if it's for a drug approval, the very first time, let's say, a lipid-lowering therapy is being evaluated, and even we're seeing this in PCSK9 inhibitors and other things, and they're setting things for the parameters for not very, very high risk, and there are age limits, and as we've all seen that the cardiovascular disease in women is actually being evaluated later in life, and by the time perhaps we're not evaluating them early enough, and by the time they come to us, they have so many comorbidities, especially chronic kidney disease and their advancing age, that it excludes them from clinical trials. And it also has to do with the fact that women make decisions for an entire family, and they think about the family. And if you ask, when you are enrolling a man in your clinical trial, he will always say, well, let me see what my wife says. And the woman will say, oh, of course you should be, and I'll bring you, and it will be all perfect. But when a woman is asked, she will say, well, I'm not so sure, I won't be able to come, I'm not so sure that I can keep up with this, and they usually don't enroll. So we need to remove those barriers and think about that and educate them in understanding that they too matter. And then, of course, the third question is educating all of us and thinking about all of the healthcare professions and finding ways to put some important resources into our clinical trials and demand them in order to enroll more women, or just design trials in women. And I think that might be a great way forward, so we don't have to deal with that. So I just think it's going to be an interesting way forward. And thank you for that very important question.